Tá. Explica para ele que é importante. Hoje eu não consigo.
Thank you. Hi, everyone. So today, in the first GBCon connection of this year, we have the pleasure to welcome Dr. Ana Garrido-Castro from Dana-Farber Cancer Institute and Dr. Cesar Santamaria from Sidney Kimmel Cancer Center, and also my colleague that will host the webinar with me, Dr. Maria Cristina Magalhães, from Grupo Oncoclínicas, Paraná. So we will start with a presentation from Dr. Garrido-Castro, who will tell us about the treatment sequence for metastatic triple-negative breast cancer. And after her presentation, we will start a discussion of clinical cases on this issue. So thank you so much, Dr. Garrido-Castro and Dr. Santamaria. It's a great pleasure to have you with us today. Anna, you can share your screen and start as you desire. Thank you.
Thank you so much, and good evening, everyone. Thank you for the invitation to speak here. And are you able to see my slides okay? Perfect. All right. So for the next 35 minutes or so, we are going to speak a bit about sequencing therapy in advanced triple-negative breast cancer. Here are my disclosures. And specifically, we're going to talk about immune checkpoint inhibition, PARP inhibition, and antibody drug conjugates. So triple-negative breast cancer has traditionally been defined by what it does not have: the lack of expression of the estrogen receptor, progesterone receptor, and lack of overexpression of HER2. And there have been many efforts over the years to try to identify a biomarker by which to call triple-negative breast cancer positive for. Here are several of the biomarkers currently listed in the NCCN guidelines for the treatment of metastatic breast cancer. Some of these are tumor agnostic, such as the approvals for immune checkpoint inhibition for patients with tumors that are MSI high or with high tumor mutational burden. But in particular, for metastatic triple-negative breast cancer, we're going to focus on PD-L1 and germline BRCA status. So we now know that pembrolizumab, the PD-1 inhibitor, in combination with chemotherapy, improves long-term outcomes in patients with metastatic PD-L1 positive TNBC. And the approval for pembrolizumab came from the results from the KEYNOTE-355 trial, which randomized patients in the first-line metastatic setting to receive pembrolizumab in combination with chemotherapy, which could have been paclitaxel, nab-paclitaxel, or carboplatin plus gemcitabine versus placebo plus chemotherapy. And in this study, the addition of pembrolizumab to chemotherapy significantly improved both progression-free and overall survival in patients, in the subset of patients who had PD-L1 positive tumors defined by the PharmDx22C3 assay and using a CPS cutoff of greater than or equal than 10%. And that comprised approximately 40% of the study population. You can see here that the benefits in terms of survival were in fact restricted to those patients with a CPS cutoff greater than or equal than 10, whereas there was no significant benefit in those with a CPS cutoff of 1% or higher in the intent to treat population. So again, pembrolizumab is now approved for those patients with PD-L1 positive metastatic TNBC in combination with chemotherapy as a first-line approach. Now, one of the questions that often arises is, what is the optimal chemotherapy backbone with which to treat patients in the first-line setting? And we know from the TNT trial that there are no significant differences between platinum or taxane-based therapy and unselected by germline BRCA status. But in those patients with germline BRCA status, there are outcomes favoring the use of platinum versus docetaxel. And so from the TNT trial, patients with triple-negative advanced breast cancer or any subtype with a known germline BRCA mutation who had received at most an anthracycline regimen in the metastatic setting were randomized to receive 6 cycles of carboplatin or 6 cycles of docetaxel. And at the time of progression, there was the option for a crossover. Approximately 90% of patients had no prior therapy in the metastatic setting, so essentially a first-line treatment approach, and 90% of patients had triple-negative breast cancer without a known germline BRCA mutation. You can see here on the left that in the intent to treat population, there was no significant difference in PFS between the platinum and taxane treatment arms. However, on the right, in those patients who carried a germline BRCA1 or 2 mutation, there was benefit favoring carboplatin versus docetaxel in that subgroup of patients. We now have 2 PARP inhibitors that are FDA approved for the treatment of germline BRCA-associated metastatic breast cancer. The first of those being olaparib, and that was based on the results from the Olympiad trial, which randomized patients with metastatic HER2 negative, either hormone receptor positive or hormone receptor negative breast cancer, who had a confirmed germline BRCA1 or 2 mutation, to receive olaparib or chemotherapy of physician's choice, which could have been vinorelbine, capecitabine, or eribulin. Patients could have received up to 2 prior lines of chemotherapy in the metastatic setting, and prior platinum in the neoadjuvant or adjuvant setting was allowed if at least 12 months had elapsed since the last dose to the development of recurrence. And prior platinum in the metastatic setting was also allowed if there had been no evidence of progressive disease during treatment. Here you can see on the right the study population characteristics, and approximately 50% of patients had triple-negative breast cancer, and just under 30% had received prior platinum therapy. There was a significant improvement in median progression-free survival favoring olaparib from 4.2 months with chemotherapy to 7 months with olaparib. The objective response rate also nearly doubled from approximately 30 to 60% with olaparib. And importantly, the median time to a decrease in quality of life measures was also favored olaparib. That median time to decrease in quality of measures was prolonged with olaparib compared to chemotherapy. In terms of overall survival in the overall population, there was no significant difference between olaparib and chemotherapy of physician's choice. However, in a subgroup analysis that was performed, you can see here, according to prior lines of therapy, that in the group of patients who had received no prior chemotherapy, so essentially a first-line metastatic setting, there was a trend favoring improved survival with olaparib compared to chemotherapy, whereas there was no significant difference in those patients in the second or third line setting. These are subgroup analyses with smaller sample size, so I would interpret the data with caution. The second PARP inhibitor now approved is talazoparib, and that was based on the Embraca study, which similarly enrolled patients with either HR positive or HR negative, HER2 negative advanced breast cancer with a germline BRCA1 or 2 mutation. Patients could have received here for this trial up to 3 prior lines of chemotherapy compared to up to 2 in Olympiad. And similarly, prior neoadjuvant platinum was allowed if at least 12 months had elapsed since the last dose. However, the protocol was amended, and this disease-free interval was modified to greater than or equal than 6 months since the last dose. Similarly, the protocol initially did not allow platinum in the metastatic setting, and that was later amended to allow, similar to Olympiad, prior platinum in the metastatic setting if the patient had not progressed on therapy. And patients were randomized 2-to-1 to receive talazoparib or chemotherapy of physician's choice, adding gemcitabine to the mix of potential chemotherapy options. You can see here the study population characteristics, slightly lower prevalence of triple-negative breast cancer patients in this clinical trial, and prior platinum therapy was also lower in this trial compared to Olympiad, again, related likely to the differences in the eligibility for platinum and those modifications during the conduct of the study. You can see here that similarly with talazoparib, there was an improvement in median progression-free survival compared to chemotherapy. There was also an almost doubling of objective response rate, and also median time to deterioration of global health status and quality of life measures was more prolonged with talazoparib over chemotherapy. Similarly, in terms of overall survival, no significant differences in the overall population between talazoparib and chemotherapy. And the authors performed an analysis adjusting for subsequent receipt of PARP inhibition and or platinum therapy, and did not identify any statistically significant differences either after this adjustment. Interestingly, so those patients with a longer platinum-free interval prior to enrolling on study did seem to have a longer duration of survival, particularly as you can see here on the left, the top left-hand corner, those patients with a platinum-free interval greater than or equal than 18 months. So we now have these two PARP inhibitors approved for patients with germline BRCA-associated advanced breast cancer. But there are initial data to suggest that there may also be benefit from PARP inhibition in patients who carry somatic BRCA1 or 2 mutations or mutations in other homologous recombination repair genes. These are data from the elaborate expanded study conducted through the Translational Breast Cancer Research Consortium, led by Dr. Tung. And you can see here that in patients with germline PALB2 mutations, although the sample sizes are relatively small, the rate of partial responses seen on study was 82%, and approximately 50% of patients in the somatic BRCA1 or 2 cohort also had a partial response to olaparib. There were no confirmed responses observed in the cohorts of patients with ATM or CHEK2 mutations, but given the data for germline PALB2 and somatic BRCA1 and 2, new cohorts for these specific alterations have now been open through this trial. Now, moving on to antibody drug conjugates, there are multiple ADCs that are either approved or are currently in development in breast cancer. 3 are currently approved across breast cancer for different breast cancer subtypes. And the 2 that we will focus on today, approved for metastatic triple-negative breast cancer, are sacituzumab govitecan and the HER2 ADC T-DXd or trastuzumab deruxtecan. So how do ADCs work? The ADCs are comprised of a monoclonal antibody that binds to an antigen, generally on tumor cells. The monoclonal antibody is linked to a highly potent cytotoxic chemotherapy payload and is linked via specific linkers, some of which are cleavable, others are not. The classical method by which ADCs work that has been described is that the ADC binds to the target on the tumor cell. That complex then gets internalized into the cancer cell, metabolized by lysosomal enzymes that then release the payload to exert its anti-tumor effects within the cell. Now, particularly for several of the newer generation ADCs, that payload can be membrane permeable and therefore exit the cancer cell and enter adjacent tumor cells that may not necessarily express the target of the ADC in the first place. And that can contribute to the so-called bystander killing effect that some ADCs have. The first ADC that we'll talk about today is sacituzumab govitecan, which targets TROP2. TROP2 is a transmembrane calcium signal transducer that has been linked to tumor progression growth in breast cancer and is overexpressed in over 80% of triple-negative breast cancers. The approval of sacituzumab for metastatic triple-negative breast cancer came from the data from the ASCENT trial, which randomized patients with metastatic TNBC who had received at least 2 prior chemotherapies, at least one of those for advanced disease progressing within 12 months of neoadjuvant or adjuvant therapy. And patients were randomized to receive sacituzumab govitecan or treatment of physician's choice, which could have been capecitabine, eribulin, vinorelbine, or gemcitabine. And you can see that there was a significant improvement in both progression-free and overall survival favoring sacituzumab govitecan over treatment of physician's choice, with a near doubling in median overall survival with sacituzumab. Also, in a subgroup analysis that was performed in the group of patients who had received only 1 prior line of therapy for metastatic disease, you can see that there were numerical improvements in median progression-free and overall survival as well with sacituzumab versus treatment of physician's choice. Interestingly, the benefit from sacituzumab has been seen regardless of TROP2 expression. Although tumors with higher levels of TROP2 expression appear to derive more benefit from sacituzumab govitecan, even those patients with lower levels of TROP2 appear to derive benefit from sacituzumab compared to chemotherapy in the ASCENT study. Here are some of the treatment-related adverse events that were observed with sacituzumab govitecan, and some of the key toxicities to monitor closely for are hematologic toxicity, including neutropenia, which in many cases requires prophylactic administration of growth factor support, sometimes short-acting growth factor support after dosing on day 1, and longer-acting growth factor support after dosing on day 8. And then also GI toxicities such as diarrhea, nausea, or vomiting. Importantly, I also want to highlight that there was an almost 50% rate of alopecia with sacituzumab on study. And there are now multiple clinical trials exploring whether sacituzumab can be moved to an earlier line setting. So this is the ASCENT-03 trial comparing sacituzumab versus standard chemotherapy in patients with PD-L1 negative metastatic TNBC, or who are otherwise not candidates for immune checkpoint inhibition in the first line setting. And ASCENT-04, which is comparing sacituzumab govitecan plus pembrolizumab to essentially the KEYNOTE-522 regimen of chemotherapy plus pembrolizumab in those patients with PD-L1 positive metastatic TNBC. We also at Dana-Farber have a few multi-center investigator-initiated studies that are looking specifically at the combination of sacituzumab govitecan with pembrolizumab in two scenarios that have traditionally been considered more immune cold settings, such as in PD-L1 negative metastatic triple-negative breast cancer, in which immune checkpoint inhibition to date has not demonstrated benefits, with the hypothesis that some of the immunomodulatory effects of sacituzumab, including activation of the STING pathway, may make sacituzumab an optimal partner with pembrolizumab in these settings. And so this is for patients in the first line setting with metastatic triple negative breast cancer that is PD-L1 negative, randomized to sacituzumab govitecan with or without pembrolizumab. And the sister trial, SACI-IO, in the HR positive, HER2 negative setting. This is for patients with metastatic hormone receptor positive, HER2 negative breast cancer with no restriction on PD-L1 status, who have received prior endocrine therapy and up to 1 prior line of chemotherapy. Again, a setting that has traditionally, in which immune checkpoint inhibition to date has not demonstrated to significantly improve outcomes. So trying to test the hypothesis of whether the efficacy of sacituzumab may be enhanced in combination with pembrolizumab. And now moving on, shifting gears to HER2 ADCs, we know that approximately 50% of breast cancers are characterized as HER2 low. That is defined as HER2 immunohistochemistry 1+ or 2+ staining and ISH non-amplified. And about 40% of triple negative breast cancers are classified as HER2 low. These were initial data presented for the ADC, the HER2 ADC, trastuzumab deruxtecan, or TDXD, in heavily pretreated HER2 low metastatic breast cancer, showing promising initial anti-tumor activity. And this led to the DESTINY-Breast04 trial, which was presented at the ASCO plenary session in 2022. And here, patients with metastatic HER2 low breast cancer who had received 1 to 2 prior lines of chemotherapy for advanced disease were randomized to TDXD or to chemotherapy of physician's choice, capecitabine, eribulin, gemcitabine, or paclitaxel or nab-paclitaxel. The primary endpoint of this study was progression-free survival, specifically in the hormone receptor positive population of the study. And as key secondary endpoints, they looked at progression-free survival in the overall population and also overall survival in the hormone receptor positive and in the overall study population. You can see here then DB04, trastuzumab deruxtecan, significantly improved progression-free and overall survival in the hormone receptor positive population and also in the global population on this study. with a near doubling here of overall survival, of progression-free survival, favoring TDXD compared to chemotherapy, and also significant improvement in median overall survival from 16.8 months in the overall population to 23.4 months with TDXD. The authors conducted an exploratory analysis in the subset of patients with hormone receptor negative HER2 low metastatic breast cancer. So in essence, HER2 low triple negative breast cancer, which comprised about 10% of the patients enrolled on study. And there were similarly numerical improvements in progression-free and overall survival favoring TDXD. You can see here the confirmed objective response rate of almost 50% with TDXD compared to 16% with chemotherapy, regardless of hormone receptor status, and the waterfall plots for response here on the right. In terms of the drug-related treatment emergent adverse events seen on study, similarly, GI toxicity and hematologic toxicity, including neutropenia and thrombocytopenia, were some of the more frequent side effects. There was an almost 40% rate of alopecia with TDXD on study. But it is very important to also note a few adverse events of special interest with TDXD, in particular, drug-related interstitial lung disease or pneumonitis. And unfortunately, there were a few cases of grade 5 drug-related ILD on study. And this highlights the importance of monitoring closely for respiratory symptoms, patient education on reporting any respiratory symptoms, and discontinuing therapy promptly, obtaining imaging and initiating steroids if there is suspected drug-related ILD. Similar to other HER2-targeted agents, it's also important to monitor for left ventricular dysfunction with routine echocardiograms. Now we know, so now that TDXD is approved for patients with metastatic HER2-low breast cancer who have received at least one prior line of chemotherapy in the metastatic setting, but we know that HER2-low is in fact a relatively unstable marker, and there have been multiple studies that have confirmed the instability of HER2-low expression from the primary to metastatic setting. We at San Antonio presented data looking at matched primary and metastatic triple-negative breast cancers, showing discordance between the primary and metastatic tumor, with more frequent conversion from HER2-low to HER2-0 tumors at the time of recurrence. And the reason for these changes is unclear. It may be multifactorial. There can be analytical factors that come into play, heterogeneity in HER2 expression, and potentially also tumor evolution over time. So this raises an important question of which time point and what type of biopsy should be used to define HER2-low status. And in an analysis, a subgroup analysis of the DB04 clinical trial, we saw that in fact, regardless of the tumor location, whether primary or metastatic tumor, or the specimen type, whether biopsy or excision resection, or the collection type of the sample, whether it was archival tissue or newly obtained tissue, that TDXD had consistent efficacy regardless of the tumor sample characteristics. And so this supports using any prior sample in the course of the disease to define HER2-low status. It does not, though, address the question of whether if there is a switch in HER2 status from, say, the primary to metastatic setting, whether the benefit of TDXD is similar to those patients who are consistently HER2-low over time. So we now have multiple therapies, ADCs, targeted therapies that are approved for the treatment of advanced triple-negative breast cancer. And where do we go from here? And I think understanding the mechanisms that drive resistance to each of these agents is key in order to understand how to best sequence therapies, ADCs, and other therapies, and if and how to best combine them. There are several novel ADCs that are in the pipeline. One of the ADCs that I'd like to mention is the TROP2 ADC datopotamab deruxtecan, or Dato-DXd. Dato-DXd, similar to trastuzumab deruxtecan, carries the same DXd payload, but targets TROP2 and also has a bystander effect, as does sacituzumab govitecan. The initial data from the phase 1 study, which enrolled multiple cohorts, including a triple-negative breast cancer and hormone receptor positive HER2-negative breast cancer cohort, showed that in TNB, metastatic TNBC, which was heavily pretreated, the objective response rate was 32% with Dato-DXd. And importantly, as noted here by the asterisk, there were several confirmed responses in patients who had received prior topo-1 inhibitor-based ADC therapy. Here are some of the most frequent treatment-emergent adverse events that were noted in both of the breast cancer cohorts, and stomatitis was one of the most frequent side effects that was seen in many of the Dato-DXd ongoing clinical trial protocols. Prophylactic mouthwash has been incorporated to try to decrease the frequency and severity of stomatitis. And Tropion-Breast-02 is a phase 3 study that is looking similar to Ascent-03 to whether the TROP2 ADC may provide added benefit compared to chemotherapy in patients with metastatic triple-negative breast cancer, not candidate for an immune checkpoint inhibitor in the first-line setting. So this study is randomizing patients to Dato-DXd or to chemotherapy of physician's choice if they are PD-L1 negative or PD-L1 positive, with either a relapse after prior immune checkpoint inhibition for early breast cancer, a comorbidity that precludes immune checkpoint inhibition, or without access to pembrolizumab in this setting. And importantly, there are also several ongoing efforts to try to better understand the effects of these ADCs in patients who have brain cancer, who have breast cancer brain metastases. And one of the efforts is the database trial led by my colleagues, Dr. Tarantino and Dr. Lin, looking specifically at the activity of Dato-DXd in patients with brain metastases. And there will be a specific triple-negative breast cancer cohort as part of this study. The data to date for ADCs in patients with active CNS disease are relatively limited. In the Ascent trial, there were few patients who enrolled on the study with CNS disease, and the response rates in the sacituzumab arm for those patients with brain metastases was an overall response rate of 3% compared to 0% in the chemotherapy arm. For HER2 ADCs, we saw at San Antonio some preliminary data from the DEBRA trial looking at the efficacy of T-DXd in patients with HER2 low metastatic breast cancer with active CNS disease. And although sample sizes were relatively limited in those cohorts, confirmed intracranial responses were observed with T-DXd. So I think efforts like Database to specifically look at the activity of these ADCs in this setting are particularly warranted. And there are other ADCs that are in development here, a few targeting HER2, so trastuzumab duocarmazine, and also disitamab vedotin, which carries MMAE as its payload, which is a microtubule inhibitor, showing some encouraging preliminary anti-tumor activity. Patritumab deruxtecan, which also carries the DXd payload but targets HER3, has also shown some preliminary activity across breast cancer subtypes as noted here, including in triple-negative breast cancer. And finally, ladiratuzumab vedotin, which targets LIV1A and carries also MMAE as its payload, has also shown anti-tumor activity in a heavily pretreated metastatic TNBC setting, also in a less pretreated one prior chemotherapy for metastatic disease. And there is currently a trial looking at ladiratuzumab vedotin in combination with pembrolizumab in metastatic triple-negative breast cancer. What do we know so far about the mechanisms that might drive resistance to ADCs? Well, the data to date are relatively limited, but we do know from several studies that there are some initial potential acquired resistance mechanisms that have been identified in paired pre- and post-treatment samples from patients treated with ADCs. Here, these are data from the Ascent trial looking at paired pre- and post-sacituzumab samples, in which a potential mechanism of resistance was identified, which was a mutation in the gene that encodes for the target of the ADC, leading to decreased binding of the target on the tumor cell. And one might hypothesize that a method to try to overcome this mechanism of resistance would be to potentially modify the target of the ADC. Similarly, there are some initial data for paired pre and post-treatment biopsies with TDXD showing a decrease in the expression of the target, in this case HER2, measured by immunohistochemistry from the pre to the post progression biopsies in 65% of patients, albeit sample sizes are limited, post TDXD. And so to test this hypothesis that it may be possible to overcome resistance to ADCs by switching the target of the ADC, we will be conducting a study through the Translational Breast Cancer Research Consortium called the TRADE-DXD study, looking at the sequence of TDXD or Dato-DXD or vice versa in patients with metastatic breast cancer who have history of HER2 low breast cancer, specifically looking at this change from a HER2 to a TROP2 ADC and vice versa. And there are already data also looking at different combinations of ADCs, including with immune checkpoint inhibitors. And from the Begonia trial, we've seen initial data looking at the combination of the PD-L1 inhibitor durvalumab with 2 ADCs in the first-line metastatic TNBC setting. The first here being Dato-DXD plus durvalumab, showing a confirmed response rate of 74%, including 4 complete responses. And as you can see here, those responses were observed regardless of PD-L1 status. And also with TDXD plus durvalumab in patients with HER2 low metastatic TNBC with a confirmed response rate of 57%. And similarly, responses observed regardless of PD-L1 status and also of HER2 low IHC category, whether 1+ or 2+. There is an ongoing clinical trial called the INSIGHT study being conducted also through the TBCRC, led by Dr. Rugo, looking at a 15-day lead-in with different therapies, including MEK inhibition, an ADC, chemotherapy, thereafter followed by the combination with the PD-L1 inhibitor avelumab. So more data to come on these combination therapies as well. So after reviewing all of these data, how do we reconcile all of the treatment options that are now available for patients with metastatic triple-negative breast cancer? I think the first-line approach hinges significantly on PD-L1 status. So for those patients with PD-L1 positive tumors, chemotherapy, either a taxane or a platinum-based approach in combination with pembrolizumab would be the preferred first-line approach. For those patients with PD-L1 negative triple-negative breast cancer, either chemotherapy, taxane or platinum, or a PARP inhibitor if they carry a germline BRCA1 or 2 mutation. And in the second-line setting, we have multiple options now available, including sacituzumab govitecan, a PARP inhibitor if they carry a germline BRCA mutation, have not previously received that therapy, and TDXD for the subgroup of patients who have HER2 low triple-negative breast cancer. Now, how do we sequence sacituzumab and TDXD? I think, so this is an important question. I think that to date, the data, the more robust data that are currently available are for TROP2 ADCs and triple-negative breast cancer. Remember, the ASCENT clinical trial was designed specifically for metastatic triple-negative breast cancer patients. DB04 for TDXD only included 10% of patients with hormone receptor negative HER2 low breast cancer, and DB04 was not powered to look specifically at the hormone receptor negative subgroup on study. So taking this into consideration, I think with the data currently available, many tend to prefer a TROP2 ADC as a second-line option, and TDXD can be considered at a later time if the patient, again, has a HER2 low tumor. In the third-line setting and beyond, in addition to the therapies that we've already mentioned, there are other chemotherapy options that are available, and also the tumor agnostic approvals for pembrolizumab that we mentioned earlier for those patients with MSI high tumors or high tumor mutational burden. There are many other therapies. So in addition to the novel ADCs, novel targeted therapies, immune checkpoint inhibitors, including bispecific antibodies that are being studied. And so we await data from these clinical trials to see where the landscape will move towards. And with that, I want to thank you for your attention. I'm happy to take any questions, and I look forward to the case discussion.
Thank you very much, Garrido-Castro. Your presentation was great. And before we start the case presentations, I would like to ask to Cesar, when you evaluate a patient with triple-negative breast cancer in a metastatic scenario, which biomarkers do you request to outline the conduct?
Yeah, so a diagnosis, I think it's important to get a thorough biomarker workup. So certainly the standard receptors, ER, PR, HER2, and then certainly we'd want to get PD-L1 status. We favor doing the CPS scoring with a 22C3 assay, because that's what was used in the keynote study. But I think also some additional important biomarkers are getting germline testing to evaluate for a BRCA mutation. And I do think also getting next-gen sequencing early on can sometimes be helpful, looking for biomarkers like tumor mutation burden, but other biomarkers that might make patients eligible for clinical trials as well. Sometimes, we'll look for like a somatic BRCA mutation. I showed some nice data from the TBCRC048 study showing activity there. So those would be the main biomarker tests to get early on.
Perfect. And any consideration about the triple-negative breast cancer in the metastatic scenario? Do you like to expose now, or we can go to the case presentations?
Yeah, I think I gave a fantastic overview of the landscape. I totally agree with everything she said there. So I agree with those assessments.
Perfect. I will share our case discussions now, and then I will share more questions. And if you wanna, the audience, if you wanna free to put some questions here at chat as well. Is everything okay with my share screen?
Yes, thank you, Chris. So I will start with the first case. This is a very interesting case. You can go to the next slide, please. So this is a 58-year-old female with a personal history of hypothyroidism and diabetes mellitus. And she had a family history of 2 aunts and 2 cousins with breast cancer at age 55 to 60. And on July 2008, she noted a breast nodule. And to resume her treatment for early disease, she underwent a mastectomy with a sentinel node biopsy, which showed a breast carcinoma of no special type, grade 3, a T2 and 0 disease, ER negative, PR negative, and HER2 low, 1 cross. She received adjuvant therapy with ACT and adjuvant radiotherapy. And after that, in 2011, she presented a local regional recurrence. And by that time, she had disease in the paroexternal region, in the chest wall, and a clavicular lesion. She received radiotherapy, and after the radiotherapy, she had a complete response. By that time, the patient refused to receive any additional systemic therapy. But after the radiotherapy, she had important toxicities with radionecrosis, and after that, she was on follow-up. And by the time, she also had a germline panel that showed a pathogenic variant in BRCA1. So she completed the radiotherapy in 2011, and in 2014, she had a new recurrence in the same place in the thoracic wall and also a perilar lymph node. She received systemic treatment with cisplatin for 4 cycles. And again, after cisplatin, she had a complete response. Her treatment was discontinued due to toxicity and due to patient decision. The radiotherapy was contraindicated due to her previous toxicities. So after that, from 2014 until 2022, she had no evidence of disease. And on February 2022, she had a recurrence in the thoracic wall and in the second left rib. I will show you the images in the next slide. She underwent a biopsy. Just one slide back, Chris, please. And only a comment, all these times that she had the recurrence, she underwent a biopsy, and all the time it was triple-negative breast cancer. So in this last recurrence, the biopsy show a poorly differentiated carcinoma, ER negative, PR negative, HER2 low, 1 cross, and PD-L1 positive. She had a CPS score of 12. So this was her image in this last recurrence. By that time, the surgeon team considered it to be an unresectable disease. You can go on, please. So to summarize, we had a 58-year-old female with a germline BRCA1 mutation, with a triple-negative breast cancer, HER2 low, PD-L1 positive, with a third local regional recurrence in the chest wall and in the second rib. And she was previously treated with radiotherapy and chemotherapy with cisplatin, with a complete response with her last treatment in 2014. So my first question is, I would like to hear you about the treatment of choice. So in case of chemotherapy, with or without immunotherapy, which would it be your chemotherapy regimen of choice? And would you consider a PARP inhibitor, considering her great response to cisplatin with many years without recurrence? Would you consider it a good option, especially considering the data that Dr. Garrido showed us about the overall survival gain of Olympiad in the update analysis for patients in the first-line setting? So that's it, and feel free if you want to discuss any other possibility.
Anna, can you start?
Would you like me to start? Sure, I'm happy to.
Thank you.
So for this patient with essentially a distant recurrence that is metastatic triple negative and PD-L1 positive, given the OS benefits from immune checkpoint inhibition in combination with chemotherapy, I think a chemotherapy plus pembrolizumab-based regimen would be preferred in this setting. In terms of the question of which type of chemotherapy regimen, given the prolonged disease-free interval or progression-free interval since prior platinum, given also the presence of a germline BRCA mutation, I think it would be very reasonable to consider platinum as the chemotherapy backbone here. We tend to reserve carboplatin plus gemcitabine, particularly for those patients who have a short disease-free interval from prior neoadjuvant or adjuvant therapy, and whom a taxane may not be a preferred option in that setting. However, again, given the germline BRCA status here, I think it would be very reasonable to consider platinum in the backbone. To the question of whether, to the question about the PARP inhibitor, I think this patient is definitely a candidate for a PARP inhibitor at some point throughout the course of therapies. But again, given the OS benefit demonstrated to date with immune checkpoint inhibition and chemotherapy, I think that would be the preferred option. The subgroup analyses that I showed from the Olympia study are subgroup analyses in a smaller subset of patients. So I do think these need to be interpreted with caution. And we do have data in the first line setting from the KEYNOTE-355 trial demonstrating the significant improvements in overall survival with immune checkpoint inhibition plus chemotherapy for PD-L1 positive TNBC.
Great. Dr. Santamaria, any comments?
Yeah, no, I totally agree with that. A couple of things I would add. With the KEYNOTE-355 study, we see that there's certainly some benefit to adding pembro to chemotherapy, and I agree. I think that's a preferred treatment option here. But we can see that pembro in breast cancer is not like we've seen in other types of cancers like melanomas or even lung cancers, with most patients still progressing after a short period of time. So, even in a frontline setting, if there's a clinical trial option, that's something also that I would consider. There's lots of next generation options in the PD-L1 positive setting that are being investigated using bispecifics or novel checkpoints. So, always keeping clinical trials in mind. And then I'll just comment generally regarding this patient's disease course. I will say it's kind of interesting that the recurrences were kind of later for triple-negative breast cancer, which just make me wonder about how indolent or not it might be. And sometimes we see certain subtypes of triple-negative breast cancer behave more indolently, and a biomarker to consider more on the research side would be something like the androgen receptor. Sometimes these triple-negative breast cancers are not as aggressive and may have, you might be seeing those kind of later recurrences versus more traditional, aggressive triple negatives.
Perfect, thank you. It's indeed a very atypical case. So we chose to give her, as you suggested, platinum-based chemotherapy with pembrolizumab. So she received from February 2022 until the current date, carboplatin, gemcitabine, and pembrolizumab for 6 cycles. After that, she had a complete response, and the chemotherapy was discontinued due to hematologic toxicities. And the patient continues to receive pembrolizumab until the current date, and she's doing very well. You can go to the next slide, Chris, please. And just another thought that we discussed, all her current disease is located to the chest wall and the second rib by continuous commitment. And in the past, in 2014, she had a perihilar lymph node that had glycolytic hypermetabolism, but now the only place of disease is this lesion in the chest wall. So in this case, would you consider a surgery for this patient? Or since she had this great response and she previously had disease at a distant site, and it would be a morbid surgery, what would you think?
Cesar, would you like to go first?
Sure, yeah. I think that's always a challenging question. So I can answer in maybe a few different layers. I think routinely, certainly, I don't think any of us are really recommending local therapies as part of, most patients' routine care. But, in these situations where there's a more oligometastatic disease, it's something to consider. In this patient, just because, again, there were other sites, and this seems like it would be a pretty morbid surgery, I would not be very enthusiastic about it.
I agree. I think also in the absence of any strong randomized data to suggest that there is long-term benefit in terms of improvement in survival with a surgical approach, I also think that surgery would not be likely favored in this setting and would continue certainly with the immune checkpoint inhibitor. On Keynote 355, the pembrolizumab was administered for up to 35 doses on study. And so if no immune-mediated toxicity or toxicities from pembrolizumab would continue with the immune checkpoint inhibitor.
Perfect, thank you. Chris, you can go with the second case.
Perfect. Well, my second case is about a female woman, a female patient with 39 years old, Caucasian, works as manicure, married, mother of 2. Previous medical history is the obesity, and no other relevant personal medical history, and abdominoplasty at age 34. No family history of cancer, denied smoking or alcohol consumption, and sedentarism. Admitted to hospital for generalized tonic-clonic seizure at March at this year, 22. And the patient's MRI at hospital admission was like this. And the patient was a very symptomatic patient, and then neurosurgic was seeing this patient at that moment. And when the oncologist available this patient, the palpable breast lump in November 2022, and breast ultrasound at this year was shown area of architectural distortion with BHAD3, and the core biopsy was performed with invasive ductal carcinoma, well to moderately differentiated, with extensive necrosis. And immunohistochemistry was ER negative, PR negative, HER2-1 cross, and Ki-67 85%. She was have some lung metastases and some other metastases with lymph node and hepatic lesions as well. And resection of one cerebral mass was performed at last month, and radiation therapy was initial at last Friday. I saw this patient today, and I have some questions about this case. The first question is, how do you approach shared decisions make with your patient with triple-negative breast cancer? Particularly with this scenario, when you have a public hospital, she was treated in the public hospital, and we have some difficulties with the access in the biomarkers and the immunotherapy as well. And we have access to tropion-2 with Dato-DXd. And which some considerations do you have in this case, in this scenario?
I'm happy to start. I'll start with a few questions. So I think in the presence, so with a newly diagnosed metastatic triple-negative breast cancer, certainly it is important to gather information, biomarker information, to help inform your treatment decisions. And so as we were discussing earlier, I think being able to complete your biomarker testing with PD-L1 status, the germline BRCA1 or 2 status as well. And in addition, NGS testing, which may open up other options and in particular clinical trials as well. So I think those are important pieces of information for a new diagnosis of triple-negative breast cancer in the advanced setting. For patients with CNS metastatic disease, and in this case, symptomatic CNS metastatic disease. In particular, I think it's very important to have a multidisciplinary approach. And so to involve radiation oncology, neurosurgery, medical oncology to define the best plan to treat the CNS lesions, whether that be with resection, radiosurgery, stereotactic radiation, and or whole brain radiation as well. And in particularly for those patients with symptomatic brain CNS, CNS metastatic disease, for that to be optimally managed from a local regional standpoint before proceeding with systemic therapy. I think in terms of, so this patient has not received any prior therapy for metastatic disease. This is a de novo metastatic presentation. I think the clinical trial consideration after appropriate local regional therapy is certainly something that we would consider. In the setting of antibody drug conjugates, also as we were discussing earlier, there are more limited data in terms of the effectiveness of these ADCs in the CNS, in particular for patients with active CNS disease. As we discussed, so from the ASCENT clinical trial, there was a small proportion of patients with brain metastases who enrolled on study with stable brain metastases. The overall response rates that were reported on that study were 3% in the sacituzumab arm versus 0% in the chemotherapy arm. There are some data that have been reported in terms of the reaching potentially therapeutic relevant concentrations of sacituzumab in the CNS. And so I think studies focus specifically on the activity of these ADCs in the CNS are clearly needed. There is now an ongoing SWOG study, 2007, looking at the effectiveness, looking at the activity of sacituzumab govitecan in patients with active CNS disease. And so I think that that would be also potentially an option to, that could be considered. In terms of other ADCs, so in the for HER2 low, for example, ADCs with TDXD, I think we have more data in the HER2 positive space for TDXD and with patients who have CNS metastases. As I alluded to from the DEBRA trial, although the size of the cohorts is relatively small, there were a couple cohorts specifically focused on HER2 low metastatic breast cancer with active CNS disease and reporting confirmed intracranial responses with TDXD. And I think there are additional efforts ongoing or planned efforts to look specifically at the activity of ADCs, of all of these ADCs in patients with CNS metastases, including, for example, the database trial that is an investigator-initiated study that hopefully will be opening soon. Regarding the sequencing of ADCs, so again, for triple-negative breast cancer, I think the most robust data to date are with TROP2 ADCs. The ASCENT clinical trial was designed specifically for patients with metastatic triple-negative breast cancer. DB04 included a small proportion of patients with essentially triple-negative HER2 low metastatic disease, and DB04 was not powered to look specifically at the efficacy of TDXD compared to chemotherapy in patients with triple-negative HER2 low metastatic breast cancer. So with more robust data, at least to date, with favoring TROP2 ADCs, I think that would be a preferred approach if we were to sequence ADCs currently for metastatic TNBC. That I still think that with the HER2 low status that we know from the primary breast biopsy that you showed earlier, TDXD remains an option, and that could potentially be used in a later line setting. But if, again, in terms of the sequencing of ADCs, I think a TROP2 ADC, such sacituzumab outside of a clinical trial, in terms of standard of care sacituzumab, would be the preferred ADC at this time. And let me stop there. Cesar, do you want to add or address any of these questions before we get to the last one?
That's a terrific overview, and I agree with everything you said. I'll just comment a little bit on the third point. What are the biggest challenges facing with these antibody drug conjugates in clinical practice? These are different than your monoclonal antibodies in terms of toxicity. And I think, we're consistently seeing higher toxicity rates with ADCs. I think even with TDM1, we all realize, this is a little more than just Herceptin. There's more toxicities we see. I think that's certainly true of sacituzumab govitecan, and with trastuzumab deruxtecan, there can be sometimes pretty serious side effects with TDX. You see sometimes lung toxicities that can be really serious. But even I think the quality of life effects, the GI toxicities, the fatigue that you see from SASI or from TDX can be really significant. And I would certainly say, at least just anecdotally, it's certainly not something that everybody can tolerate. I think there's certainly very active drugs. I think they're really important in treatment consideration, but we're still also, as we're developing new treatments and treatment combinations and whatnot, I think just keeping in mind the toxicity issues are really important, and defining the patients who we think really will benefit from these is really important as well.
I think it also underlined.
How do you monitor the lung toxicity of TDXD? How do you do this? Like a clinical trial, or do you have some clues to share with us?
Yeah, I mean, for the most part, it's clinically, right? Patients are getting routine scans. You're seeing patients regularly, and I think you just want to pay close attention to, respiratory complaints. If it's at all suspected, we usually have a very low threshold to involve the pulmonary docs, there are guidelines based on how significant the respiratory toxicities are in terms of holding treatment, that you just want to be careful with, because particularly with the lung toxicity, it can progress to be quite severe. So I think just being acutely aware is certainly an important part, but I'm not aware of any other routine testing like PFDs or anything like that. Any additional thoughts about that?
No, I agree. I think attention, particularly to close monitoring to respiratory symptoms, and also patient education. Emphasizing the importance of reporting early any respiratory symptoms and having a very low threshold to image, to stop therapy, initiate promptly steroids if there's a suspicion for drug-related ILD.
Okay. And do you perform multiple biopsies to find HER2 low, or you can just biopsy the first metastatic setting, or do you consider the first biopsy and you try to find some HER2 low at some point?
Happy to take this question. So for HER2 low status, as we saw from DB04, the benefit from TDXD was seen regardless of the sample type that was tested. So whether it was a primary or metastatic tumor, whether it was an archival sample or a more recently or freshly collected sample prior to enrollment, the benefits were seen consistently with TDXD compared to chemotherapy, a physician's choice. That said, so in someone who already has a HER2 low breast cancer sample, you already have the potential indication for TDXD based on the biomarker. For those patients who are consistently HER2 zero at different time points, say from the primary metastatic setting, from the primary setting to the time of recurrence, I do think there can be added value to repeating a tumor biopsy at the time of progression. Also for the purposes of NGS testing, if there are any acquired mutations over time with treatment that may potentially open other clinical trials or other treatment options as well. So I do think that can be considered. I think what these data, as we mentioned before, what the data from DB04 do not specifically address at this time is whether if there is a switch in HER2 low status from, say, the primary to metastatic setting, from, say, HER2 low to HER2 zero, if that patient will benefit similarly from T-DXd as a patient who is consistently HER2 low over time. There are also data looking at heterogeneity in HER2 expression, even from tumor samples from different anatomic sites collected at the same time, showing discrepancy in HER2 status, and also even within the same anatomic site, differences in HER2 scores as well in samples also collected simultaneously. So I think there certainly is also a need to try to improve our methods of quantification of HER2. There is discordance and intra-observer variability with IHC scoring of HER2, and improved methods for quantification of the target, I think is certainly an area of interest at this time.
Perfect.
I'll just add to, as a pearl, when you're getting your biopsies in the metastatic setting, the one metastatic site just to take with a grain of salt is going to be your bone biopsies, where the decalcification process can affect, your HER2 immunohistochemistry. So you just want to consider that. It's not that it can't be done, but you could get a false negative potentially.
Perfect. Do we have two questions here? The first one is, would you consider maintenance with pembro or pembro plus gemcitabine at first case?
So in the last case, that the previous one that we discussed, that the patient discontinued treatment with chemotherapy due to toxicity and continue receiving only pembrolizumab. In this case, would you consider maintaining one chemotherapy with pembrolizumab?
Or just pembro?
I think consider the patient had a complete radiographic response, correct? So taking that into consideration and the hematologic toxicity, I think continuation of single agent pembrolizumab would be reasonable. If and when there's progression, certainly a change in therapy and reconsideration of chemotherapy or other options could be considered. But given the excellent response to therapy and the prior toxicity, I think continuation of single agent immune checkpoint inhibitor would be reasonable.
Perfect. And the second one is, do you see any rationale to dose reduction considering ADC toxicity?
I think you would, start treatment at standard doses, but I do find myself dose reducing more often than not. So, I think you just kind of go by how the patient's doing. But I do think you want to start off at a standard dose. I wouldn't do an upfront dose reduction. That's what that question was referring to.
Chris, can I make two questions?
Of course.
The first one is about ILD. So the clinical trials were very cautious with grade 1 ILD that was maintained over time. So patients had to discontinue the trial due to grade 1 ILD that was persistent. In clinical practice, how are you dealing with it? For a patient with grade 1 asymptomatic ILD that does not recover with time, are you discontinuing? Are there any patients for whom you would consider maintaining the TDXD despite grade 1 ILD.
Cesar, do you want to go first? Or...
Sure, yeah. I'll be honest, I'm not sure I've seen a lot of lung disease just anecdotally in my personal practice. I've seen more of the GI toxicities, you know, I think it's a pros and cons kind of situation. Where is the patient in their treatment? You know, do they have other options in terms of treatment? You know, I think what the studies and guidelines are reflecting is just, you know, being really cautious even at a low level of toxicity. But I think just practically speaking, you know, you have to see the patient as an individual. You know, if they have other treatment options or, you know, they're otherwise doing okay, I would have lower thresholds to discontinue and switch therapy.
Okay. The second one, just a quick question outside our main topic. For HER2 positive disease, just to go further in the central nervous system metastasis. So Anna mentioned that the local therapy are still very important for brain disease, but for patients with small asymptomatic lesions, do you think there are patients for whom we can avoid local therapy and start like TDXD alone?
So I think that's a great question. For HER2 positive metastatic breast cancer with active CNS disease. So we have data first with the HER2 CLIMB regimen, looking at capecitabine, tucatinib, and trastuzumab. And that is certainly one option to consider in the second line setting for patients with active CNS disease after a taxane and trastuzumab-based and pertuzumab-based approach. There are also data for TDXD in patients with CNS disease. Just recently, DB12, so Destiny Breast 12, close to enrollment, which is a study specifically looking at the activity of TDXD in patients with brain metastases, hoping to provide more insight into the activity of these agents in patients with CNS metastatic breast cancer. So, you know, I think in patients in whom the disease is asymptomatic, and in the opinion of the treating providers, there isn't an urgent need to start local regional therapy. I think in individualized scenarios, one can consider a systemic therapy approach, and there are options, as we've discussed, of highly efficacious agents in this setting for patients with CNS disease. Cesar, I don't know if you have any other thoughts.
Yeah, no, I agree. I think, you know, the systemic options for CNS disease are more fleshed out in HER2 positive breast cancers. You know, I do find it's a little more challenging with triple negative.
Thank you. I think we have time for the third case. It's a quick one.
Yes.
Okay. So this last case is a 46-year-old female with no personal or family history of cancer. She is treated in our public health system, so we don't have germline panel available here. In July 2020, she was diagnosed with breast carcinoma of no special type, a T3N1, grade 3, ER negative, PR negative, HER2 low disease with a Ki-67 index of 80%. She received a neoadjuvant ACT and had a pathologic complete response. After that, she received adjuvant radiotherapy, and unfortunately, just into January 2002, she had a recurrence in central nervous system and in the liver. It was a single lesion in the central nervous system, so she underwent a surgical resection. and the pathology showed the metastasis of breast carcinoma with ER negative, PR negative, HER2 low, with a Ki-67 index of 80%. After that, she received a stereotactic brain radiotherapy and started first-line capecitabine. Also, we don't have available immunotherapy in the public health system, so she received capecitabine alone. In November last year, she had a disease progression in the liver, and by that time she had a high volume of disease in the liver and also abdominal lymph nodes, and with no evidence of disease in the central nervous system. And the liver biopsy showed a breast carcinoma with a HER2 status. So the discussion again is about the treatment of choice. Anna showed that we had more robust evidence to consider sacituzumab govitecan as a second-line agent, but I would like to hear your thoughts on this case. Also, if she still had untreated brain lesions or high volume of brain lesions, would this influence your treatment of choice or your sequence of treatment between ADCs, since we have some data of the activity of T-DXd in brain lesions?
Yeah, I guess, it depends on what's available. If you have, sacituzumab available, I think that would be a reasonable second-line option. And yeah, you get the added bonus of potential CNS activity. But I think, the CNS activity, especially if it's significant, you really want to think about your local therapy options, whether it's, radiation or surgery. In patients with these kind of like high volume liver disease, it can be very challenging. And I realize, she doesn't have access to pembrolizumab, but, there is data suggesting that the liver is a cold immunologic site, and responses to immunotherapy tend to be a little lower in liver metastasis, possibly due to tumor microenvironment factors. A regimen sometimes that I'll consider kind of in these kind of high liver metastasis burden situations is something like gem-carbo. It can be pretty active, and you can give it even with LFT abnormalities.
Okay. So, and Anna, about the HER2 status in the liver, would this influence the use of T-DXd in your opinion?
So this patient had previously HER2 1+ breast cancer at diagnosis. So making this patient a potential candidate for T-DXd after receipt of one prior line of chemotherapy in the metastatic setting. As we've talked about today, and I think sacituzumab, if available, would be a preferred treatment option in this setting. But T-DXd remains an option that could be considered at a later time, given the initial HER2 1+ status. So again, we don't have data on switches in HER2 status from the primary to metastatic setting and whether loss or difference discordance in HER2 IHC may impact efficacy of some of these ADCs, but at least to date, given the initial HER2 1+ results, she would potentially be a candidate for T-DXd, and that could be considered later on.
Okay, this patient was enrolled in a clinical trial evaluating ADC combination, and she is doing really great, really impressive response.
It's great to hear.
Great.
I think we don't have, let me check, any additional questions. We are on time.
Yes.
So thank you, Chris.
Thank you very much for your brilliant considerations and contributions. Thank you for accept the invitation. and for our first GBICAN connection at this year. Thank you very much. Thank you, Renata.
Thank you all. Bye-bye.
Thank you.
Thank you.
Bye-bye.